Part 2. The objectives for today are to review wound healing, to identify the stages of pressure injuries, to outline healable, non-healable, and maintenance wounds, to discuss etiology and wound classification, to reinforce the importance of wound measurements, to review research in wound care, and lastly, to introduce the concept of wound hygiene. So we're going to start with a question from the content from our first session. What are the 4 phases of wound healing? So to those of you online and those of you in the room, does anybody know any of the phases of wound healing?
What?
Inflammatory was said.
Granulation, yeah.
Granulation. All right, is there anything in the chat box?
No, you need to tell them to put it into the chat box.
Oh, I didn't tell them. Sorry. So yes, you can put the answer in the chat. So the 4 phases of wound healing to those on the line. Does anybody have anything they want to add? Okay. So the wound healing process, I'm not going to go into great detail as this material was covered in part 1. However, this is an important refresher as successful wound management is dependent on the understanding of the normal repair process. The wound healing process is a cascade of events beginning with injury to tissue. There are 4 phases of wound healing. Phase 1 is called hemostasis, also known as clot formation. This is initiated immediately after injury occurs to the tissue. Vasoconstriction occurs to stop the bleeding and reduce the bacteria from entering the site. The second phase of wound healing is inflammation, as somebody mentioned here. This is the body's defense mechanism to protect itself from bacterial invasion. As the cells recognize foreign protein or damaged tissue, they bind to it, they engulf it, and they destroy it. Inflammation is normal and will resolve itself. This is the phase where chronic wounds are typically stalled, and we'll talk about that a little bit more as well. Phase 3 is proliferation, also referred to granulation, as mentioned here, epithelialization, and contraction. So this is when new growth occurs. This phase contains the overlapping of collagen deposits, angiogenesis, which is the formation of new blood vessels, granulation, wound contraction, and epithelialization. The tissue is very fragile. The cells eventually begin to differentiate into the various layers of skin. And the final phase of wound healing is the maturation phase, also known as remodeling. This is the phase where the closed but not healed wound gains its tissue strength. This is the final and longest phase, and it's ongoing, and it's to strengthen the tissue. Scar tissue refers to the thick fibrous tissues that take the place of the healthy ones that have been damaged. It's important to note that scar tissue regains about 80% of its original strength. It's never as strong as its pre-injury state. Remodeling occurs as the wound continues to contract and fibers are being reorganized. Remodeling can continue for 3 weeks up to as long as 2 years. So although the stages of wound healing are linear, wounds can progress backwards and forwards depending on internal and external conditions. Okay. So as you may recall from Wound Care 101, Part 1, there are 2 types of wounds, acute wounds and chronic wounds. Acute wounds is one that progresses through the phases of wound healing without any complications. And our chronic wounds are ones that fail to progress through all the phases or to do so without complications. So we're going to do a quick review of staging pressure injuries as per the National Pressure Injury Advisory Panel. There's no trick questions here. We're looking at wounds only just to practice the staging. So again, these are all pressure injuries, and this is only intended to be a quick review. So for those of you in the room, please feel free to call out the stage that you think the pressure injury may be. And for those of you online, please feel free to use the chat to participate. Okay. So here we have partial thickness loss of skin with exposed dermis. The wound bed is viable, pink, red, and moist. There's no slough, eschar, or granulation tissue present in the wound bed. So what stage is this pressure injury? Good. So we have our stage 2. So also remember that a stage 2 can be a serum-filled blister that is intact or ruptured. Okay, here we have intact skin and a localized area of non-blanchable erythema. What stage is this? Good, stage 1. What do you think the treatment plan might be here? Offloading? Anything else that you're going to incorporate? Diet changes, yeah. Sorry, did you say something?
Barrier cream.
Yep, yep. The barrier creams. Okay. So for that stage and any stage, there's a lot of things that you're gonna consider, and as you mentioned here, that covered a lot of them. Offloading's important, nutrition's important. There's a lot of things that you have to look at. So here we have full thickness skin and tissue loss. However, the extent of damage cannot be determined as the wound bed is not visible due to slough or eschar. How'd you stage this pressure injury? Good.
Smart.
I know, I know. So this is unstageable, you're correct. And just a quick reminder that stable eschar, meaning dry and intact on the heel or ischemic limb, should not be softened or debrided. All right, next we have intact skin with a localized area of persistent, non-blanchable, deep red, maroon, purple discoloration. What stage is this?
You'll just find it the deep purple.
All right.
Keep going.
Purple discoloration.
Is there anything in the chat?
No, does anybody want to take a stab at it and put it in the chat box?
Nothing? Okay. So this is a deep tissue pressure injury. So just a reminder that a deep tissue injury can be intact or non-intact skin. It can also be a blood-filled blister. Okay, so here we have a full thickness loss of skin and tissue with exposed bone. Slough or eschar is visible. However, it's not obstructing the view of the wound base. What stage is this? We have our stage 4. So what might be some things that we're concerned, or the main thing that we're primarily concerned about if we're at a stage 4? Yes, yep, that's right, osteomyelitis. So anytime muscle, tendon, ligament, cartilage, or bone is exposed or directly palpable, we treat as osteomyelitis until it's ruled out. And lastly, here we have a wound with full thickness loss of skin. We can see that we are through the epidermis and dermis layers of skin, and the damage extends into the subcutaneous tissue. However, we do not see or directly palpate any underlying structures here. What stage is this? Good. Yeah, we have our stage 3. So again, remember for stage 3, you often see undermining and tunneling, adipose is visible, granulation tissue. You often see rolled wound edges with chronic wounds, and slough and eschar may be present, however, not preventing visualization of the wound base. Okay, so this concludes our recap. And again, if you'd like to view part one, it is available on our website and we'll have that come up on the last slide as well. So we're going to move forward. This was the final slide of Wound Care 101 Part 1. So we had discussed the components of a comprehensive wound assessment. And this slide is just to remind everybody that we're looking at the whole person, not just the wound. A holistic assessment will help determine and mitigate causes, as well as determine wound management interventions to support the individual in living with a wound and achieving the best possible outcomes. It's important to understand not everyone is able to heal their wound, and it's crucial for the team to work together to determine an appropriate plan of care. So let's try and put some of these pieces together. In wound care, it's important to identify goals reflective on prevention and or the healability of a wound. With that, a healable wound is one where the blood supply is adequate and the individual is capable of healing their wound. The causative factors can be eliminated, managed, or treated, and the goal is full wound closure. It's also important to note that for healable wounds, you would have the resident and or their family members engaged and participating in the care plan. All right, a non-healable wound. A non-healable wound is one with insufficient level of arterial blood flow to the wound to support healing. Due to irresolvable comorbidities and risk factors that cannot be modified, such as systemic disease, medications, or poor nutrition, the individual is unable to heal their wound. For example, this could be an individual with a malignant tumor or major organ failure, or someone that is end of life. And finally, we have maintenance wounds. These are wounds which the blood supply is adequate and the individual has the capability to heal their wound. However, there are individual wound and or system factors that cannot be eliminated, resulting in wound healing that is slow or stalled. This could be due to factors such as lack of resources, poor adherence, or not understanding the treatment plan. So this could be the resident that chooses not to offload, or someone that is a diabetic and won't adhere to a nutritional plan. So these would be your maintenance wounds. Is everybody good with that? Okay. So what do you think some general goals of care would be for non-healable and or maintenance wounds? Again, for those of you online, feel free to use the chat box. And for those of you in the room, what do you think? What could some goals of care be for these wounds? Yes, keeping free of infection. Yep, to try and prevent it from progressing. Is there anything in the chat box, Bernadette?
No,
Okay.
quiet group today.
Yeah,
Yeah,
and
that's
keeping
right.
dry, absolutely. So the goal for non-healable wound is to enhance individual comfort and function, slow the course of deterioration, and reduce the risk for infection. For non-healable wounds, local wound care is aimed at the reduction of bacteria and moisture. So great job at identifying that to those of you here with me. Moisture retentive dressings may not be appropriate in these cases. Also, this may encompass conservative debridement, which we'll talk about shortly as well. Managing limitations and risk factors are important, especially for maintenance wounds. Non-healing wounds are devastating for individuals, potentially causing long-term morbidity and impaired quality of life. They also incur a huge health economic burden for healthcare services. Okay, so far between session 1 and session 2 to this point, we've reviewed the wound healing process, identified the types of wounds, staging pressure injuries, comprehensive wound assessments, which I have on the screen right now as a refresher, and we've just covered healability and goals of care. So we've also had sessions on skin tears, we've had the lower limb assessment, and we've also had nutrition and wound healing. So how do we begin to put all of this together? Let's start by taking some time to elaborate on etiology. Simply put, etiology is defined as the cause. Is it pressure? Is it moisture? Is it a skin tear? Is it on the lower limbs? Could this be a venous or arterial ulcer? Is it on the foot of a diabetic? So believe it or not, one of the bigger challenges that we face is trying to determine the etiology of a wound. It's essential to differentiate pressure injuries from various other wound etiologies, such as arterial ulcers, venous ulcers, or diabetic foot ulcers. For example, assessing a resident with a wound on their foot, one must determine whether that wound is caused by pressure, diabetes, ischemia, trauma, or a combination. Understanding the etiology in terms of how to appropriately assess, classify, and treat wounds is essential to optimize resident outcomes. Although this seems like a straightforward component of the assessment, it can be complex, especially when dealing with the lower extremities. So again, etiology is defined as the cause, not to be confused with contributing factors. We're looking for the specific root cause. All right, so let's take a closer look. Again, it can be difficult to determine whether a wound on the foot should be classified as a pressure injury or a foot ulcer. A pressure injury is easily defined, as we just reviewed. However, there can be confusion when an individual develops wound over a pressure area on the foot. A comprehensive assessment, including a lower limb assessment, like the one pictured here on the screen, is imperative. When the predominant factor is disease-related, such as diabetes, neuropathy, arterial disease, for example, the wound should not be considered a pressure injury. So, a pressure injury is localized damage to the skin and underlying soft tissue, usually over a bony prominence related to a medical or another device. And this was the definition put out by the National Pressure Injury Advisory Panel in 2016. For pressure injuries, the pressure on the bony prominence compresses the vessels. This leads to ischemia. The source of the pressure is removed, and moist wound healing is appropriate as adequate blood supply has been restored. Unlike the wounds of the lower extremities, such as arterial ulcers, ischemia is caused within the vessel. The goal is to keep these wounds clean and dry until or if the area is revascularized. Moist wound healing principles are not appropriate here due to the inadequate perfusion. A moist area with no perfusion is the ideal environment for growth of bacteria. So remember the root cause. Why is this wound not healing? Another important note, do not classify wounds on the toes as pressure injuries. These wounds are typically related to trauma from external forces such as footwear. Our treatment plan is to dry these wounds out as if they're arterial ulcers. Therefore, we classify them as such. Okay, so let's look at some examples for context here. We have a 53-year-old male, diabetes for 20 years, non-smoker, ischemic wound created by pressure from his work boot, and a deep tissue infection is in progress here. The cause of the wound is poor tissue perfusion and possibly diabetic neuropathy. Because of this, pressure over the bony prominences on the lower extremities places them at risk for trauma from external forces. If perfusion was adequate and if neuropathy was not a factor, this would not have likely happened to someone because they wore their everyday work boots. For that reason, this is classified as a diabetic foot ulcer. Let's look at another example. Here we have an 82-year-old female, no diagnosed arterial compromise, ex-smoker. The wound was discovered during morning care at a long-term care facility 4 weeks ago. At times, it shows signs of slight improvement, but will regress back to the status here on the photo. So the next step would be a detailed lower limb assessment, which should have been done by this point. And based on the findings and the inability of the wound to heal, according to best practice recommendations, the treatment would be to dry this wound out, which is an arterial ulcer treatment. So this wound would be classified as an arterial ulcer. So this is the second time we've spoken about the lower limb assessment. There are resources available on this topic, and again, this was featured in a previous Wound Care Wednesday. So the recording for that is on our website, and please reach out to our team if we can help you with that.
So that was established just because, of its location, because it was ideal, under ideal conditions, like the pressure relief and so on and so forth.
Yes,
So therefore, there's not adequate circulation to
yes,
heal it. So
exactly.
lower arterial, that's your
Switched
presumption.
over.
Yeah.
And that's the whole lower limb assessment. as
Yeah,
part
we
of
haven't
that.
been doing that, so. We watch that.
Mhm. All right, so another thing that comes into play, which is a common area for incorrect wound classification, is moisture-associated skin damage versus stage 2 pressure injuries. So let's do a side-by-side comparison. They look similar. Close inspection and assessment are needed to differentiate the two. The etiology of the first picture is moisture, therefore classified as moisture-associated skin damage. The etiology in the second picture is pressure. So this is classified as a stage 2 pressure injury. As you can see, the characteristics of a stage 2 pressure injury can be used to describe the appearance of moisture-associated skin damage. I also want to take a minute to note the chart here at the bottom and point out IAD, which is incontinence-associated dermatitis. This is the most common form of moisture-associated skin damage. So something to keep in mind for your residents. Okay, before I move on, is everybody okay with what we've covered so far? Yes, okay. Nothing in the chat? Okay. So just some quick notes as a reminder regarding wound measurements. Surface area is measured length times width. The most common method of obtaining wound measurements is the longest length by the perpendicular widest width. Measure wounds at least once per week unless change is noted in the wound bed, and you will likely need a cotton tip applicator and a ruler. Sometimes measurements do vary, especially on the buttocks area. Some may measure the wound as it is, or some may pull apart skin folds and take a measurement to visualize the wound bed. So just be sure that you include in your documentation how you obtain the measurements, because depending on which way you measured it, it can be quite a difference. So I added a box here with a diagram to provide a visual on differentiating tunneling from undermining. As you can see, tunneling is a narrow opening or passageway that can extend in any direction through the soft tissue. Undermining is defined as the open areas under the wound edges from the destruction of tissue. It may surround some or all of the wound edges and extend in different directions. Unlike the length and width measurements, tunneling and undermining are documented using the clock method. So consider the wound as the face of a clock with 12 o'clock at the head and 6 o'clock at the feet, as pictured here over to the side. And lastly, don't forget to measure the depth of the wound. This is very important component of your assessment. Wound care is evolving.
Is there any point at which the undermining becomes so deep that you would term it as tunneling?
It depends on if it's narrow. So if you are looking at undermining, you can document that as the range. So it can be undermining from 3 o'clock to 6 o'clock or 9 o'clock to 12. But if you're looking at a narrow area that can't be captured in that way, I would call that tunneling. Does that answer your question? Okay.
Because sometimes it's so deep that we've had that discussion before, whether it's tunneling or
Mhm.
whether it's undermining, because the
Yeah.
undermining can go deeper
Mhm.
than just immediately at the periwound.
Absolutely, absolutely. And the wound bed, everything can change as well. Tissue can fill in, or there could be more tissue damage. So the big thing is to capture where it is and the size.
Yeah.
Okay, so wound care is evolving. Wound healing is a science. It requires understanding of normal wound healing, causes of delays of wound healing, and the management of wounds. Every wound must be treated individually with regard to etiology, chronicity, location, and the level of microbial contamination, as well as individual factors that affect wound healing. Due to complexity, research is always ongoing. Advances in wound care are directly related to research. Proven research guides best practice. In Nova Scotia, the foundations of best practice for skin and wound management by Wounds Canada are utilized. The widespread utilization of these recommendations allows consistency in prevention strategies, comprehensive assessments, collaboration, holistic care planning, continuity of care, and evaluation of care plans to determine achievement of the specific goals of care and optimization of individual outcomes. It's important to note that these recommendations have been developed by experts and are based on latest research. Best practice recommendations for the prevention and management of wounds introduces the wound prevention and management cycle. The cycle is intended to illustrate an easy to understand process that can be used by care teams in all settings for any individual with a wound or at risk of developing wounds. This is regardless of the environment and the healthcare system in which the team lives and works. There are 5 steps. They are to assess and or reassess, set goals, assemble the team, establish and implement a plan of care, and evaluate outcomes. Each best practice guideline is organized and presented in this cycle. So as you're reviewing them, you will see that they are broken down this way. Assessments must identify all relevant factors, while interventions must acknowledge and align with the individual's culture and values. Effective use of the wound prevention and management cycle takes all these factors into account and will result in a more complete, individual-focused, sustainable process. Okay. Is everybody okay with that before we move to the next thing? Yes? Nothing in the chat? All right. So, what is wound hygiene and why is it important? Well, wound hygiene is a newly established concept, March of 2020, actually. This concept of proactive wound healing has been proven effective in research studies, especially against hard to heal wounds. Wound hygiene has gained its own identity as an anti-biofilm approach and is now a term that encompasses a 4-step protocol being increasingly used across wound care. The impact of biofilm in delaying or preventing healing is currently in the spotlight. There's a consensus on the need to remove biofilm and then prevent its reformation to kickstart healing. Wound hygiene is a flexible strategy so that it can be implemented by all practitioners on some level, regardless of their expertise or specialty. So let's start this off with discussing biofilm. So you know when you go to bed at night and get up in the morning and you have that sticky film on your teeth, or if your pet has their water dish and it has a slimy film after a while until you change the water, that is biofilm. Biofilms are composed of a network of bacteria and embedded in thick, slimy barrier of sugars and proteins. A biofilm is formed within minutes to hours of skin breakdown and adheres to the wound surface. This biofilm barrier protects microorganisms from external threats, making them resistant to standard treatment. So just a few facts on biofilm. During normal healing, the progression from inflammation to proliferation, so phase 2 to 3, only takes a few days. The inflammation phase is where the wound healing often stalls or fails, and this leads to chronic hard to heal wounds. So we talked about that when we were looking at the phases of wound healing. Generally, microorganisms pose no threat to the host unless the skin is damaged, so a wound, allowing entry into the system. High levels of bacteria without diversity can result in biofilm. 60 to 90% of chronic wounds contain biofilm. In more recent literature, clinicians agree that it can be assumed that most, if not all, wounds that are chronic contain biofilm. Okay. So delayed healing is considered a sign of biofilm colonization. Biofilm grows rapidly with extensive regrowth in wounds demonstrated within 48 hours. Wound hygiene is designed to address this, and to promote healing, the biofilm must be managed early. So how does one practice wound hygiene? Wound hygiene is a 4-step regime designed to comprehensively clean a wound and prepare it for healing. So we have cleanse, so cleansing the wound and peri-wound with every dressing change. Debride, which is removal of necrotic tissue and slough, foreign bodies, and biofilm. Refashion, which is refreshing wound edges. And dress, so dressing selection based on moisture management. Wound cleansing is a key component in wound management. So just to go through a few tips and reminders. As per Wounds Canada, the core principle of wound cleansing is the application of fluid to a wound with each dressing change to disrupt biofilm and remove devitalized tissue, contaminants, foreign debris, and dressing residue. So it's important to cleanse thoroughly using a gentle force as tolerated. As some say, you are not anointing the wound. You need to really cleanse it to disrupt biofilm. So that's really important when we're looking at chronic wounds. Again, assuming that they all contain biofilm and knowing the strength of biofilm, it's really important to clean thoroughly and apply a little bit of friction and gentle force as long as the resident is tolerating it. Cleansing of the peri-wound and surrounding skin encourages overall healthier healing environment and can help prevent infection or increase bioburden in the wound. Does anybody here in the room know what amount of area that the peri-wound is defined as? So if you wanted to guess, if you had to cleanse the peri-wound, how far away from that wound would you cleanse? How far around the wound do you cleanse? Yeah, that's the 10 to 20 centimeters. So this is to remove the dead skin, the scales, and the callus, and to decontaminate the area.
Lindsay told us 20 centimeters in the chat box.
Okay, thank you, Lindsay. So depending on the type of wound and the location, for example, if it's venous stasis breakdown over the legs, Don't underestimate the power of soap, water, patting dry, and a good moisturizer. This is also important for prevention. Best practice recommendations indicate at least 100 mils of cleansing solution is required to cleanse a wound. So that may seem like a lot, but again, to thoroughly cleanse a wound, it does take quite amount of fluid and cleaning, whatever you're using, often normal saline. So this is why the normal saline that is in the picture is designed this way. So it has 100 mils in it. And also, when you're using it directly on the wound, it applies a therapeutic pressure,
12 PSI.
12 PSI. All right, so again, speaking of pressure, between 4 and 15 PSI is sufficient and safe to cleanse or irrigate a wound without adversely impacting cellular activity, vital to wound healing, or inoculating the underlying tissue with bacteria. Regarding irrigation, do not irrigate a wound with a base that cannot be visualized. Undermining sinuses and tunnels can only be irrigated when there's a known endpoint and all of the irrigation fluid can be retrieved. Okay, so up next is a question that comes up a lot, especially in long-term care and in dealing with chronic wounds, and that is clean versus sterile technique. So I'm going to start this slide by defining aseptic technique. Aseptic technique is a technique used to limit the transfer of microorganisms from one person to another by minimizing microbe count, preventing cross-contamination, and this includes sterile, no-touch, and clean technique. The decision regarding the appropriate aseptic technique, so sterile versus clean, is made based on the resident's clinical condition, the wound etiology, the wound location, the invasiveness of the dressing procedure, the goals of care, and I really want to highlight it also depends on the facility or agency policy. All long-term care facilities does have a wound management policy, so you should be familiar with it and know that what's expected in the facility in which you work. Okay, so this information did come directly from the CLIC website, and I'm not sure if you remember, but that is Connecting Learners with Knowledge. It is a great resource and has a lot of policies and procedures on there that aligns with Wounds Canada's best practice recommendations. So this slide is a chart from the International Wound Infection Institute's Principles of Best Practice from 2022. And this just elaborates on making these decisions. So again, just so we're on the same page, sterile technique is the use of sterile gloves, sterile field, tray, instruments, sterile solution, and sterile dressings. Only sterile gloved hands or instruments are used for direct contact with the wound. Then there's a variation in the middle referred to as no-touch technique. So this is the use of clean gloves, a sterile field, a sterile dressing tray, sterile instruments, and solution and dressings. Only sterile instruments are used for direct contact with the wound. And then we have clean technique. This is the use of clean gloves, a clean field, a clean or sterile dressing tray, clean instruments, and clean solution and clean dressings. Clean gloved hands or instruments are used for direct contact with the wound. Is everybody good with that before we move on to debridement? Yes. Okay. So as we covered, biofilm is present in most chronic and hard to heal wounds and delays the healing process by prolonged inflammation. These wounds require one or more debridement methods for biofilm removal and to stimulate healing. While there are several methods of debridement, the purpose remains unchanged, and that is the removal of necrotic tissue, slough, debris, and biofilm from the wound. So consider the various methods of debridement. For example, sharp debridement requires specific training, whereas autolytic debridement involves allowing the natural physiologic process to occur, as shown here in the pictures. Healthcare professionals must ensure they are competent in both the cognitive and technical aspects of debridement prior to performing it. Therefore, appropriate methods of debridement must be considered, as well as one's scope of practice. It's important to note that debridement of a wound that does not have adequate vascular supply is not recommended. Therefore, thorough assessment or vascular assessment including a vascular assessment is needed to determine whether or not you're going to debride. So in thinking about a diabetic, our first plan of action would not be to debride that wound, knowing that there's not enough blood supply to heal it. So again, we want to dry that out, and that's where our poster comes into play, no foam on feet. So this is just a quick slide to outline the types of wound debridement out there. Not going to go into a lot of detail, as not all these types are practiced in long-term care or Nova Scotia for that matter. Some key factors in deciding which method would be time, environment, tissue selectivity, pain, exudate, infection, and cost. Research and best practice are to be followed. For example, wet to dry dressings are no longer best practice. Again, I would defer you to your policy and your scope of practice. So let's move on with refashion the wound edges. So again, this is refreshing the wound edges. And this consists of removing non-viable tissue such as slough, eschar, callus, scales, and debris from the wound edges that may be harboring biofilm. Properly maintained wound edges that align without rolled edges or maceration, such as pictured here on the screen, are common in chronic wounds. This will allow epithelial advancement, wound contraction, and move the wound closer to closure. So lastly, we have dressing the wound. So we could probably talk for hours on this. There are many factors to consider, but we do have a few basic guidelines. So don't forget to protect the peri-wound. This encompasses cleansing as discussed, drying, and using a skin barrier, and allowing it to dry before applying dressings. There's a no sting barrier that is on the provincial formulary. You want to consider the goals. Is this wound healing, non-healing, or maintenance? Is the priority bacterial burden or tissue toxicity? It could be a healable wound where you're trying to promote granulation, or this could be a palliative wound where you're focusing more on moisture control and keeping it free from infection. So you're going to base your decisions on assessment findings. Not all wounds respond the same. What works for one wound may not work for another. This is why it's important to understand your assessment findings and the products that you're using. So address residual biofilm while preventing and delaying its regrowth by using dressings containing antibiofilm or antimicrobial agents. Antimicrobial dressings are not just for infected wounds. They can be used to prevent biofilm reformation in hard to heal wounds. We caution you that many companies will say that their product is the newest one for biofilm prevention or treatment. So this is why research is really important, and we can assure you that the antimicrobials that are on our provincial wound formulary have research to support that and case studies to back that up. Consider the amount of moisture in the wound. Is the goal to dry it out or to add moisture? Choose a dressing that can manage exudate effectively, thereby promoting healing. Consider the wound size and location. You want to choose something that will appropriately dress the wound and stay in place. Other things to consider are cost, availability, and wear time. Again, this all comes down to understanding your assessment findings and understanding the products. The last component of dressing selection that we're going to talk about is packing a wound. The purpose of packing a wound is to loosely fill dead spaces, facilitate the removal of exudate and debris, and encourage growth of granulation tissue from the base of a wound to prevent premature closure and abscess formation. The type of packing chosen is dependent upon the wound assessment, goals of care, and wound care management goals. So, you're going to fill the entire depth of the wound to the surface. Do not leave space anywhere in the wound. Use a cotton tip applicator to press the material into the smaller areas of the wound. Ensure the space is loosely filled with packing so it does not create pressure against the healthy tissue. Too much pressure could lead to decreased blood flow and impair new growth. Take the packing apart, fluff it, don't stuff it. And use only one piece of packing wherever possible to avoid a piece of packing being left in the wound. If it is unavoidable, make sure you count and document upon insertion and removal. You could also leave a little pigtail in it that you can see and easily retrieve. So I think that answers our initial question of what is wound hygiene and why is it important? It's no surprise that longer healing times are associated with increased morbidity and reduced quality of life. So this is wound hygiene in a nutshell. Cleansing, debriding, refashioning wound edges consistently prior to the application of a dressing to manage biofilm. It's going to support optimal wound healing. Keep this in mind as all chronic wounds are assumed to have some degree of biofilm present. And that is it for the presentation. So we are done recording.